start, sir. Very good evening to everyone. Welcome everyone for this clinical case presentation. Before we start, I'll request KSCASI Chairman, Dr. Narayan Chandra Hebsur, to do the initial remarks and welcome address. Hebsur, sir.
Thank you, Chandru. I bring a very warm welcome to all of you. Our special moderator today, Dr. Arun, my close friend, and Dr. Anil, Dr. Rajgopal Shenoy sir. I welcome you all, and Dr. Subramanyam. You all are welcome for this wonderful evening. I request you all to please start the session. We have a panel of great people who are real legends in clinics. And now Akshada is going to present. Wish you all the best, ma. Kindly proceed.
Yeah, before that we begin. Today's Dr. Akshada Easwar. So she is a final year DNB resident. Today's session will be moderated by Dr. Arun Kumar N, Senior Consultant and Unit Chief and Additional Medical Superintendent, St. Martha Hospital. And we have faculty as Dr. Rajgopal Shenoy, Senior Professor of KMC Manipal. And we have Dr. Subramanyam S G, Professor of Surgery in St. John's Medical College. And we have Dr. Anil Kumar, Senior Consultant, Baptist Hospital, Bangalore. So I request today's moderator, Dr. Arun Kumar sir, to begin the session. Arun sir.
Thank you, Dr. Hebsur and Dr. Chandrashekar. We'll start with the presentation. Before that, I just want to inform that, all the others in the meeting can put on their queries or whatever they want to comment in the chat box. And I will look into that in between and take it from there. Thank you. Akshada, you can start now without wasting much time. You can start off now. Yes, with the presentation.
Very good evening to everybody. I am Dr. Akshada. I am a final year postgraduate in general surgery from St. Martha's Hospital, Bangalore. Before I start, I would like to thank the Karnataka State Chapter of ASICON and all the great faculty and professors here today. And a special thanks to Dr. Arun Kumar sir, my moderator for today and head of unit. So, just a second.
Okay.
Sorry for the delay. So I'm presenting the case of a 72-year gentleman, a farmer from Karnataka. He came to the OPD with the complaints of yellowish discoloration of eyes and urine since the past 1 month, on and off black discoloration of stools since the past 1 month, and upper abdominal pain since the last 5 days. The patient first noticed yellowish discoloration of the urine, which was insidious in onset since the past 1 month, before which he was apparently asymptomatic. Along with that, he also noticed yellowish discoloration of his eyes since the past 1 month. The discoloration of his eyes has a waxing waning pattern where the discoloration comes down intermittently and then increases in intensity again. The patient also complains of generalized pruritus since the past 1 month, and this pruritus is more during the night times and it has reduced in severity for the past 2 weeks. He also gives history of passing black tarry stools with on and off passage of normal yellow stool since the past 1 month. And he has a history of right upper abdominal pain since the last 5 days, which is insidious in onset, has been dull aching in character with no aggravating or relieving factors. He has a history of loss of appetite and unquantified weight loss also. However, there is no history of fever, postprandial fullness or steatorrhea. There is no history of vomiting or hematemesis. Cough, hemoptysis, abdominal distension are not present. He does not have history of diplopia, seizures, any bony pains or backache. The patient does not have any known medical comorbidities or history of previous surgeries. There are no history of similar episodes of jaundice in the past. He has not taken any treatment for his present illness, and he has no history of high-risk behaviors, blood transfusions, or any chronic drug use. He consumes a mixed diet and has normal bowel habits except for the discoloration. His sleep has been disturbed because of the pruritus. He does not have any urinary complaints. The patient is a chronic smoker with a history of 40 pack years of smoking, but he says he has abstained from smoking since the onset of his symptoms. He's a non-alcoholic. There is no family history of jaundice or malignancies running in the family. So to summarize, this is a 72-year-old gentleman with no medical comorbidities who is a chronic smoker with complaints of waxing and waning yellowish discoloration of eyes and yellowish discoloration of urine, with generalized pruritus and occasional melena since the last 1 month, and right upper abdominal pain since the last 5 days. There is also a history of loss of appetite and unquantified loss of weight.
Okay, we will interrupt you at this point. Sir?
Yes, sir.
Can I, sir?
Any history of fever?
No, sir.
Fever, chills, rigors?
No, sir.
No. What do you think of why is he having melena?
With the waxing waning jaundice, sir, with the high discoloration of urine, it seems to be obstructive jaundice. And in cases of obstructive jaundice, if there is melena, we would suspect a periampullary lesion, sir.
Yeah.
You said chronic drug use. Now, what drug specifically did you ask?
Sir, basically for IV drug use, sir, because that would increase the chances of hepatitis B or C, which can cause liver cell failure.
IV drug use. What about oral drugs? Did you ask? In a patient with
yes,
jaundice.
sir.
Yeah. What drugs?
Jaundice can be caused, sir, by paracetamol abuse also, sir. Liver cell failure.
Okay. Paracetamol abuse. Whereas if you give for any indication, any drugs are there chronically prescribed by us, which can cause jaundice.
So B complex vitamins can cause a yellowish discoloration of urine, sir, but not for
jaundice. I'm talking about jaundice.
Jaundice.
Not sure, sir.
Long-term medication means what you can think of? INH, rifampicin.
Yes, sir. For tuberculosis.
Thioprin.
Yes, sir.
NSAIDs, and more importantly, ART. These are the things which we prescribe for long term and which can cause
jaundice.
You said about melena.
Yes,
what
sir.
about pale stools? You didn't comment.
Sir?
You didn't comment about pale stools. You said melena and normal stools.
Yes, sir. He does not give any history of clay-colored stools, sir. He is telling in between his episodes of melena, there are times when he passes normal yellow-colored stools.
Okay. Does he really say that he has got waxing and waning of the jaundice?
Yes, sir. He is telling that the intensity of the jaundice is coming down in between, not to the baseline. It is not becoming normal, and then the intensity is increasing again.
Because I hope you know why this waxing and waning of the jaundice occurs.
Yes, sir.
But with just 1 month history, can you expect waxing and waning?
Usually, no, sir. It will happen because of necrosis of the tumor, sir. So it should be more advanced.
It should grow back to produce obstruction again, and it should necrose.
Yes,
then jaundice should come down. So even if
yes,
what small tip is that you need not put everything, whatever you elicited. If it does not,
yes, sir.
History.
Next question. What is your possible diagnosis with this history?
This is looking like a case of obstructive jaundice, sir. He's a smoker with pruritus, with high-colored urine and high-colored sclera. And since there is a history of melena with unquantified weight loss, loss of appetite, it could probably be a malignancy, sir, in the periampullary region.
Okay, the next question is, what is Thomas sign?
Thomas
sign?
I'm not sure, sir.
Silverfish?
Thomas, okay, sir. The stools might be silver colored in this patient, sir. So because of obstructive jaundice, the stool will be clay colored. And when there is on and off melena, the mixing of the blood in stools with the clay colored stools might produce silver colored stools in these patients.
The fatty stools mixed with the melena and clay colored stools giving the silver oxidized
silver color. Yes, sir.
So I would like to ask you, Akshada, 1 or 2 questions after 2 examiners have asked you. Most importantly, age and smoking. Anything related to your diagnosis? First question.
Yes, sir. Both the age of the patient, sir. He is 72 and he has a 40-pack year history of smoking. Both give rise to have a higher chances of pancreatic adenocarcinoma, sir.
Why is that so? How is smoking connected to this carcinoma, what you're talking about?
So the smoke itself and the components of the BD or cigarettes are nicotine, and all of them are proven carcinogens, sir. So they increase the risk of pancreatic adenocarcinoma.
So why do you think there is abdominal pain in this patient?
Sir, abdominal pain is the one history which does not fit into the diagnosis of malignancy, sir. But in case he has coexistent stones, or if the gallbladder is distended, then he can be having pains.
Or there can be early onset cholangitis,
Yes, sir.
which can come. Of course, fever is not there, which you did not elicit, but fever, chills, rigors, and pain, all these things, you can expect cholangitis.
Yes, sir.
Sir, Shenoy, sir?
Does the patient complains of mass for abdomen? No.
Patient does not
So
complain any
in
mass.
that case, even negative history does not complain of mass is important.
Yes, sir.
And you should even the history you should elicit and present with open mind, saying that don't think that you are dealing only with obstructive jaundice. It can be medical jaundice also.
Yes, sir.
Sir, Shenoy, sir? You're there, sir? Sir, Shenoy, sir?
Sir, disconnect ಆಗಿದೆ. Just continue, sir. I'll just call him.
About the smoking, you told about the smoking. I don't think it is a direct effect. It is those, whatever you said, they are metabolized in the liver and excreted in the bile. So that's the reason why you have this increased carcinogenic effect, especially in lungs, probably, chronic smokers. Okay. Any other thing further? Dr. Anil and Dr. Subramanyam?
No previous history suggestive of biliary colic. No, your voice is breaking again, I think. Yes.
Can you hear, sir?
No, it's not clear.
Sorry. Can I ask one or two questions, sir? Quickly.
Sir, please, sir. We are waiting for you.
A smoker and a 72-year-old. Obviously, both are risk factors. So that is what you have asked. Okay, number one. What is the difference between intermittent jaundice and waxing and waning jaundice? Commonly asked question.
Yes. So intermittent jaundice, sir, it will come back down to the baseline. So there will be a period when the patient is not icteric. Whereas in waxing and waning, it will come down and go up again, but it will never touch the baseline.
So why do you think this happens in intermittent jaundice, especially case of stones?
So in stones, if the stone is causing obstruction of the CBD, if the stone will pass off, it will clear the biliary tree and allow for drainage of the bile, sir. So there will be no jaundice anymore.
Not necessarily completely pass off. It starts moving, and when the inflammation settles down. So that is one thing.
Yes, sir.
Whereas in a periampullary or ampullary carcinoma, what will happen? Why is this problem?
Yes, so there are tumor cells in the periampullary region. When they undergo necrosis,
don't say tumor cells.
Tumor cells will block.
Let's say central necrosis. Okay.
Central necrosis of the tumor, and when they slough.
Yes. So what is the importance of knowing fever and chills and rigors? This question was asked to you, is there any fever? Correct? Yes.
Yes, sir. We want to know if there is any associated cholangitis, sir.
Which is more common in a stone disease or malignancies?
Stone disease, sir.
Why? Because this is an important thing you should know. Yes.
Yes, sir. Blockage of the CBD, sir, it will produce a mucocele or a empyema of the gallbladder.
No, not what I'm trying to tell is stones always occur in the background of infection. No, that's what it is. Second infection is more common. Whereas here, malignancy is obstructing. As of now, there is nobody has intervened in that unless patient has high risk. Now, I just wanted to ask you, apart from smoking and age, what do you think the highest risk factors for the carcinoma pancreas in general? 2 or 3. We say this in breast also, we ask this question.
Yes, sir. Alcohol is also
No. Alcohol can give rise to, longer chronic pancreatitis, which per se can give rise to what? How much? Rough idea about? See, we do see lots of this chronic pancreatitis in our places. So about 5 to 10 12% like that. But
Okay,
more
sir.
than any other risk factors, strong risk factors. Well, so that's the importance of knowing this hereditary pancreatitis, number one. So when you
Yes, sir.
take this history, past history, family history,
Mm.
and second is first degree relative having a pancreatic malignancy.
Yes, sir.
And of course, so list is quite big, including diabetes. Diabetes is also a risk factor.
Okay.
In what way you can correlate diabetes to this disease?
Mm.
I will give a clue to you.
Yes, sir.
Patient has got 20 years diabetic. This problem you suspect. Patient has been having diabetes for 20 years. Now
Yes,
he
sir.
has developed malignancy of the head of the pancreas. It is possible. One of the risk factors. I will put it other way. Patient develops a recent history of diabetes in a patient who had recurrent abdominal pain. Like, what do you suspect?
Recurrent abdominal pain, sir, chronic pancreatitis might cause endocrine insufficiency.
Exactly. So chronic pancreatitis, recent diabetes, then of course head mass, short history of jaundice. This is what you have to suspect in that direction.
Yes, sir.
So hereditary pancreatitis, very high incidence. So these are some of the important points you should note.
Yeah.
Only last question to you from my side is, why the urine is high colored in a obstructive jaundice?
In obstructive jaundice, sir, the conjugation occurs normally. So it is the amount of conjugated bilirubin which is high in the circulation, and that is directly soluble in the urine, sir. So
you have to use the word water soluble.
Water soluble.
Because, why I ask this? Because in the case of hemolytic anemias,
Yes,
is
sir.
unconjugated bilirubin.
Yes.
Why you don't get high colored urine?
Because the liver will not bear the hemolysis.
No,
Unconjugated.
not that. I'm not talking about liver level now. Urine.
Because it will
It
not
is
be
albumin bound.
insoluble, sir. Yes,
It is
sir.
unconjugated. So that is the reason. So it cannot be excreted
Soluble
in
in
the
the
urine.
Yes, sir.
Okay. So soluble and insoluble.
Yes.
So that's why it's called acholuric jaundice. Correct, no?
Yes, sir.
Yes.
We'll move on to
Please go ahead, sir.
We'll move on to the examination. Before that, a couple of comments and questions in the chat box which I would like to ask. How do you explain the pain?
It could be due to a coexistent stone, sir, or distended gallbladder, either a mucocele which is causing
Now, don't jump into stones now at this stage, okay? Because your patient, 72-year-old, waxing waning, you are
looks
always
like malignancy.
kept one diagnosis in the mind, okay?
Yes, sir.
Now your worry is I have to explain this upper abdominal pain since 5 days. So what may be the possibilities?
Over distended gallbladder,
Yes.
sir, which is called.
Another comment is just a jaundice of 1 month with black stool of 1 month. Why periampullary CA first diagnosis?
There is no previous history of on and off abdominal pain of biliary colic. And there is other supportive history also, sir. It is obstructive jaundice. There is weight loss. There is loss of appetite, anorexia. So that is why, sir. Age is the supportive factor, is a smoker, sir.
See, the loss of weight
That is
also,
nothing.
you have not quantified what is the loss of weight. Huh?
Yes, sir. Patient did not tell, sir. He just told that his clothes have loosened, sir. He did not give how
Because
much
1
weight.
month history, so much loss of weight, little difficult to.
Difficult to, yes, sir.
Huh?
Okay.
Whenever you tell loss of weight, you need to quantify also,
Yes,
if
sir.
possible. Okay.
Shall we move on to the examination?
Yes, sir.
So
Yeah. Akshada, examination.
Yes, sir. The patient was examined in a well-lit room.
upper
after-
abdominal pain, since this was asked.
Yes, sir.
Go ahead. Please go ahead.
The patient was examined in a well-lit room after obtaining informed consent and adequate exposure. He was well built and moderately nourished, well hydrated, with a BMI of 22.3 kilogram per meter square. He had a ECOG performance status of 1. Icterus was noted in the sclera and the bulbar conjunctiva. However, there was no discoloration of palms and soles. Pallor could not be appreciated. There was no clubbing, cyanosis, pedal edema, generalized lymphadenopathy, and scratch marks were present over the bilateral upper and lower limbs. There were no signs of liver cell failure. He was afebrile on examination with a BP of 130/80 by 80 millimeters of mercury in the right brachial artery in supine position. He had a heart rate of 84 per minute in the right radial artery and a respiratory rate of 14 cycles per minute. His room air saturation was 98%. On inspection, the abdomen was flat. The umbilicus was central and inverted. The corresponding quadrants moved equally with respiration. There was no fullness or mass visible on inspection. The skin of the abdomen was normal. There were no engorged veins, no visible peristalsis or pulsations. Some branding marks were present on the abdomen, which he gives history of from childhood, and the hernial orifices were noticed to be free. On palpation, a 5 by 4 centimeter globular mass was palpable in the right hypochondrium. The mass extended medially 5 centimeter from the midline and laterally extended up to the right mid-clavicular line. Inferiorly, it extended 5 centimeter from the right subcostal margin. The mass was minimally tender. The plane was intra-abdominal. Lateral, medial, and inferior borders were palpable, but the superior border could not be appreciated, and fingers could not be insinuated between the mass and the costal margin. The surfaces were smooth, and the consistency was firm. The mass moved with respiration. Liver and spleen were not palpable. There were no other masses palpable in the abdomen. The external genitalia and bilateral testes were normal. There were no evidence of free fluid in the abdomen. Bowel sounds were normal. Percussion was dull over the mass. Per rectal examination, there were no skin tags, fissures, no palpable lesions, and stool staining, melena was present. There were no palpable supraclavicular lymph nodes, and the rest of systemic examination was within normal limits. So I would like to give a provisional diagnosis of obstructive jaundice, probably due to periampullary carcinoma.
So the panel, please. Questions?
One thing is you need to mention that patient is fully conscious, alert, cooperative.
Yes.
Because in a case of jaundice, we don't know what is his consciousness level. Okay, that is very important. What signs of liver failure did you look for in this patient who is just 1 month of acute jaundice?
The first to appear would be spider nevi, but in chronic liver disease, we can have
spider nevi?
Extremities and trunk, sir, back and trunk mostly.
I don't think. It's more over the chest. Okay, then.
Yes, sir.
Okay, Dr. Akshada, 1 or 2 things that in the general examination, heart, what's the pulse? You mentioned, I think, HR. You are talking about heart rate or pulse rate?
Yes. Heart rate, sir.
No, don't do such mistakes, okay?
Yes.
Because in the, you are no doubt you will auscultate the heart, it's different. We generally, why it's important to know this pulse rate in obstructive jaundice? Just wanted.
So in obstructive jaundice, there can be bradycardia, sir. If the bile salts will...
What may be the reason for that?
The bile salts can deposit in the sinoatrial or the atrioventricular nodes and also cause irritation of the vagus nerve, sir.
So vagotonic effect. So there is something called as a vagotonic effect is also there. So what all these things will tell you, respiratory rate, SpO2, saturation, that means patient is not in sepsis or cholangitis or something.
Yes,
and you have showed that, sclera. Does it look very, you can, how to grade that by looking at the color, more or less. I am not trying it perfect, but typically in a hemolytic disorders, what type of discoloration you get?
Lime yellow, orange yellow, or greenish yellow.
And look at your patient, show that eyes once. Yeah, just look at that.
Yes, sir.
So why do you think it's not that green?
It's not very
greenish.
green,
Normally you get that kind of a thing.
Yes, sir.
So why is that light color now? See, you can see that.
Yes, sir.
Why?
It could be in the waning phase, sir.
So that is what is the explanation in your patient.
Yes, sir.
Probably you can still make out a pallor if you carefully examine in your patient, particularly. Yes, so these are some of the important things which you should keep it in mind. And of course, this is a completion sake. You mentioned about scratch marks in the limbs. Abdominal wall is more nearer. Scratch marks is also little related to where your hand goes easily. There's also that. In addition to all that explanation which we have given.
Right.
Okay. Yeah. So next,
jaundice.
Move.
Jaundice. Yes. Where do you look for jaundice? You said palms, skin, sclera. Where else you can look for?
Oral mucosa and tongue we can see. Oral mucosa and tongue also we can see, sir.
Tongue.
More specific in oral cavity.
Palate, hard palate.
Hard palate.
Hard palate.
And
abdomen also we can see, sir, in deep jaundice.
Okay. And a few things you missed out. Maybe flanks you have to comment. Back you are not examined. It's a part of abdomen examination.
Yes, sir.
It should be complete, whether you are dealing with abdominal mass or pain abdomen or whatever. It's incomplete without examination of the back.
Back, yes, sir.
And external genitalia has to be commented even in inspection.
Okay, sir.
You said in palpation, I think. Inspection you missed out.
Yes, sir.
Peristalsis, pulsations, it should come. See, once you become consultant, that is different. As a post-site, you should present everything.
Yes, sir.
Can you have show me the inspection of the abdomen, that slide? Yeah. So that's what I think more important has been already mentioned, the flanks fullness. Why is that important? Just now, sir gave you that clue.
Ascites, sir, early on will present as fullness.
So does this patient take alcohol?
No, sir, he's non-alcoholic.
So then what is the importance of that word? What do you mean by engorged veins? Just why not use the word dilated veins? Don't get into engorgement. Yes. I'm not trying to say wrong or right at this juncture, but simply use the word and that dilated veins. Where do you look for the veins?
We can look around the umbilical region, sir, for caput medusae. Caput medusae, sir. It is a sign of portal hypertension associated with liver cells.
And in this patient who, let us say, he does not have he has not taken no portal hypertension, but suppose you find veins. Where do you find the veins and what is the explanation in case? Okay, I'll give a clue. Lateral veins from below upwards. Flank vein.
Yes, that can be a sign of IVC obstruction.
So
the tumor
be a large liver masses, yes. large one. So that's what you should also keep it in mind. Umbilicus, any comments? I think Dr. Jairam Shenoy has put it.
Yes, put a comment telling that umbilicus is
more transversely stretched. Look at that.
Yes, sir. It is a stretch, sir. Horizontally stretched.
That's one thing. And anything else? Yeah, we'll talk about it. Central, inverted, you have written. But anything, sometimes in a malignant cases, we expect you to mention for negative point there. Malignant cases. Baby carcinoma, stomach, colon, pancreas, large ones. Yes?
Nodule, sir.
So look for it. What you look is important.
Right.
And when you suspect any ascites, stretching, all that thing, look for cough impulse. Remember, these are the things which are fundamental so that you will not miss anything. Okay.
Right. Sir.
That means we examiners will give you credit. She has looked for umbilical hernia because this is an intra-abdominal mass.
Yes.
So she has looked for cough impulse. She has looked for umbilical nodule. She has looked for stretching, all that things. Okay.
Right.
Yes.
What about mobility of the mass?
Just go to the next slide, then explain that. Yeah.
The mass was mobile with respiration, sir. The was having tenderness, so I could not elicit intrinsic mobility, sir. It was tender.
Okay.
You said pruritus. What is the cause of pruritus?
The bile salts get deposited underneath the skin, sir. So they irritate the free nerve endings. And also there are some receptors, sir, the cholinergic receptors which get irritated, which causes itching. And sir, sometimes in liver cell failure, histamine can be related, sir. That may also cause itching.
Okay. There's another question in the chat box. Will a yellow sclera clear up in days? How long does it take for the sclera color to clear?
Not sure, sir.
So what indirectly means is, suppose you operated on this patient, let us say today. So do you think tomorrow it will go? That's what you are decompressed. Let us put it that way.
No,
what is it basically? Sclera contains what tissue is that? Elastic. It will take minimum 10 to 15 days of time. I think somebody can correct it if it is. So that's what we generally tell. It takes some days. My side, one or two other questions to you at this juncture. Tender gallbladder, you said. Tender, correct?
Yes, sir.
So now you retrospectively patient had right hypochondriac pain also.
Yes, sir.
So what do you think probably the cause of this tenderness, since you said tender?
Just over distension of the gallbladder itself can cause tenderness, sir.
But according to you, what is not matching? What is the jaundice?
For a malignancy, sir, it should be painless.
No. What I'm telling is not clear. Jaundice is almost clearing.
Yes, sir.
That means back pressure is, that's what
relieved.
You see
Yes,
that
sir.
the sclera is not
Come
even
down.
that dark.
Yes.
So I think probably whether it is going for infection, I do not know. Whether it's diabetic patient, some infection or whatever it is. So tender gallbladder, yes, definitely it is over distension, correct? Stretching of the capsule, all that we tell, but probably right now there is no fever. So, but keep it in mind. Or do you
Yes.
think it's enlarged liver itself? You felt that enlarged liver? No.
Liver is not palpable, sir.
Liver is not at all palpable.
No, sir.
That's only this distended gallbladder.
Gallbladder, yes, sir.
Okay, all right. So this is what a few things are important here. Mass, don't write minimally tender. I mean, I know people use the word slightly tender, but tender is tender. Intra-abdominal.
Yes.
Once you said moves with the respiration, that means it is intraperitoneal.
Yes, sir.
Why did you put that word intra-abdominal? Say straight away intraperitoneal.
Intraperitoneal.
Why?
Yeah.
Because it moves with
respiration.
So in other words, in the examination, we don't expect you to write intra-abdominal like this here. You are eliciting clinical signs.
Yeah.
Mass in the right hypochondria moves with respiration. It is give
Right.
the chance to the examiner. What does it tell you? Then you
Okay.
give the answer. Intraperitoneal.
Yes.
That's what we expect. We expect you to take shifting dullness, present or not present. Interpretation, examiner will ask you the question.
Right.
What other mass you checked here? Liver, spleen, you are written. Why spleen in this patient?
Again, sir, liver cell failure, portal hypertension can be there.
That you are told in that the patient is not alcoholic, no stigmate of whatever. Is that the reason that only alcoholic patient portal hypertension gets splenomegaly, or any other cause in relation to the carcinoma pancreas? We'll come to specifically.
Portal vein thrombosis might also.
More than that, yes, splenic vein thrombosis, more so not from the head region, more from the body end, right? So that is what is one of the possibilities. So you say look for enlarged spleen. Anything else you have to look in a patient like this?
No free fluids, sir. No shifting dullness was there.
No, you have written mass. No, one is yes, liver definitely you have written that. Nothing. Spleen you have mentioned. Patient has no ascites, correct?
No ascites.
So then what else you can look for?
No supraclavicular lymphadenopathy, no Bloomer shell.
Abdomen. That is not, I'm just talking abdomen. Means think of for some time, whether it's a colon, stomach, what are the regional metastases you can pick up by palpation. You understood what I'm telling? Thin patient, yes, you can also pick up something else. Apart from the umbilical nodule, anything else? You look for it. May not be in this patient, paralytic nodes. Okay. So where do you get them?
In the epigastric region, sir.
So it's above the umbilicus, the epigastric. Thin patient, especially other malignancies, you do get. So that should be your no other mass palpable means examiner will ask you this question.
Right.
Okay, this is how you proceed. Excellent. Next. Yeah, she has written there, no free fluid, but inspection wise, that's what they should have told you. Why did you say bowel sounds are normal? Correct? That is auscultation. Yes. Then why did you move to percussion after that?
Yes.
No, don't do such, that's why we have told you that day to put slide numbers. Now, since you are not put, I'm trying to, that's why go by one slide. That's the thing. Okay. And in a case like this, see, you have written there, what is it? No skin tag, fissure, and all that thing. What is the most important thing anybody expects in a case? Yes, melena you have written. But anything else in any malignancy in the abdomen, what people expect?
Bloomer shell, sir. No palpable lesions are there, sir.
No, lesion. See, don't comment. Lesion is anybody will tell lesion.
Yes, sir.
Lesion can be hemorrhoids, lesion can be fissure, lesion. So you have to look for certain things specifically.
Right.
Okay. That's where, so stool staining. So then, of course, I've been already told back and, those things have been told to you. Examination. Yes, sir. Diagnosis?
Your diagnosis.
Obstructive jaundice, sir, probably due to periampullary carcinoma.
Why did you tell that? Why not head of the pancreas? What do you mean by periampullary, the word, and head proper? Or why not any other possibility? Say I will tell differential diagnosis.
Sir, head of pancreas carcinoma usually will have a progressively increasing jaundice, and melena might not be present, sir. In periampullary carcinoma, which is within 2 centimeters of the ampulla of Witter, there can be waxing waning jaundice with history of melena.
So you don't consider any other possibility, like if you are asked?
Differentials can be there, sir. Carcinoma of head of pancreas can be there. CBD, cholangiocarcinoma can be there, and sometimes, rarely, even carcinoma gallbladder may present with jaundice.
How?
What about stone disease?
It can be stone disease, sir, but associated history is suggestive of benign disorders.
Like
benign disorder.
Sir?
No, you give more importance to the history or the findings or your assessment?
Sir, even on the findings, gallbladder is palpable, sir, so unlikely to be due to stone disease.
This time, I think you should be able to tell about law, no? Supervisor's law.
Yes, sir.
Law.
In a case of obstructive jaundice, sir. Yes, in the case of obstructive jaundice, if the gallbladder is palpable, it is seldom due to gallstone disease.
You said just now that it could be carcinoma gallbladder, correct?
Yes, sir.
Where? Where means?
Usually the neck, sir. The neck of the gallbladder, sir.
Why not fundus?
Then, sir, if the neck is free, bile will still drain, sir. So the gallbladder will not become. There will be no obstruction to the flow of bile, so gallbladder will not become palpable.
No.
Neck is the narrowest part, so it will cause obstruction.
So the neck of the gallbladder, there is a malignancy. So with the distended gallbladder, correct?
Yes, sir. Yes.
Then why patient has obstructive jaundice?
Sir, obstructive jaundice in carcinoma gallbladder can be due to multiple reasons, sir. One, if there is a node at the porta hepatis which is compressed the CBD, or in case it is an advanced malignancy of gallbladder with multiple liver metastasis, or in case there is a coexisting stone disease, sir, with carcinoma of gallbladder.
So advanced lesions, that in the region of the neck with the lymph nodal mass compressing, but your patient has got, these are differential diagnoses. Particularly waxing and waning is there, and you have got a palpable gallbladder.
Yes.
So keeping those two in the mind, you would like to consider, this is my diagnosis. Weight loss, how much weight loss?
He does not quantify the weight loss.
Sorry, you are told that. You are told that point. Yes.
What are the exceptions to the Kruiser's law? Any idea?
Yes, sir. Double impaction of stones, sir. One in the cystic duct and one in the CBD can cause an exception to Kruiser's law.
Why? How does it cause?
The gallbladder will still become distended, sir. One stone is at the cystic duct, so there can be a mucosal or associated empyema of the gallbladder. There will still be obstructive jaundice because of the CBD stone. And then mucosal or empyema gallbladder, sir. Or a perforated gallbladder with a gallbladder mass, sir, where omentum or colon is stuck.
Perforated gallbladder, most of the time it will be very acute, isn't it?
Yes, sir, acute history.
You will have, even if it is malignancy and perforation, they will have acute symptoms. Here he doesn't have that, and omental mass and all, it's very, very advanced.
Yes, sir.
The double impaction is accepted.
Yes.
Any other
mucosal? Mucosal or empyema of the gallbladder?
Chronic cholecystitis unlikely.
Chronic, no, sir.
No. That is one exception is that double impaction of the stone. Any other exceptions,
they'll tell oriental cholangiocarcinoma will present like this, sir, but
not oriental cholangiocarcinoma, oriental cholangiohepatitis.
Okay.
Chinese liver flow. Any idea how does it give the exception?
Not sure, sir.
No. Okay. And even in obese patient, no, you may not be able to feel the gallbladder.
Right, sir.
Can it be a biliary stricture?
It can be a biliary stricture, but there is no history suggestive of it, sir.
Like what history you expect?
The biliary stricture can be either iatrogenic, sir, or due to stone disease, sir. There is no history of biliary colic or.
Can you get palpable gallbladder with a biliary stricture?
Yes, sir, but again, it will be due to a malignancy, sir. Lesion at the periampullary region.
Lesion anywhere below the cystic duct insertion
Cystic duct.
to
the CBD.
To the CBD, you can
Yes.
get obstructive jaundice with palpable gallbladder also. It can be a benign stricture or it can be a malignant stricture, but history is not conducive for the biliary stricture. Okay. What other causes are there apart from periampullary carcinoma to cause obstructive jaundice?
There can be just a cholestatic phase of hepatitis which can cause obstructive jaundice, sir. Primary sclerosing cholangitis can cause obstructive jaundice.
Okay.
And choledocholithiasis itself can cause obstructive jaundice, sir. Post-operatively, iatrogenic biliary strictures or bile leaks can present with obstructive jaundice.
No, in the presence of gallbladder, I'm asking. The presence of this sort of a gallbladder.
Yes, sir.
Any ampullary adenoma also can cause. Need not be always a carcinoma.
Malignancy.
Okay.
Yes, sir.
Any ampullary adenoma. Sometimes this ampullary dysfunction. Rarely, sometimes the ampullary dysfunction can cause this sort of jaundice, and of course, in this patient, it is more likely to be malignancy. Looking at the other features.
Yes.
Akshada, one question to you. Why you are telling that this is palpable gallbladders? Globular, you said some 3/4. I will tell it, say metastasis, one single large metastasis in the liver.
Yes, sir. It is present in the right hypochondrium in the mid-clavicular.
I'm telling the same spot. There is one big, rapidly growing metastasis. Patient has melena, according to you. I say he's got some carcinoma colon. I just want to know from you. Firstly, vaccine and everything is there, but
yes, sir.
Examiners are not convinced. Say jaundice is not very deep.
Yes,
I'm just
sir.
asking you how. Yes, tell.
It is not in continuity with the liver border, sir. The margins of the lesion.
Very good. So inferior border of the liver. So this is basically you are telling there's no enlargement of the liver itself.
Liver itself. Yes,
Even
sir.
when the liver is enlarged, you palpate that entire liver. Yes, you will find a step like down there.
Yes, sir.
And also one question has been asked to you by Sir Subramanyam. What is that? Mobility. In case if you get mobility, what is the type of mobility you get in this type of patients?
Side to side mobility will be there.
So these are some of the points to you to help, but there can be some objections also that. But this is how you have to tell in the examination. Evidence also. Right. Sir, any other?
Even there is one more like if it's a hydatid cyst with the rupture into the biliary tree, you can get obstructive jaundice. But of course, patient will have palpable liver and all those things.
Yes.
So that is also one of the reasons why you can get. Of course, it's a rare cause, but you can get obstructive jaundice in such a situation. Okay.
Another couple of comments in the chat box. Clonarchy sinensis. Dr. Ravi Shankar has commented. Do you think that can cause any pathology in the liver? Dr. Akshada?
Or that is one of the cholangiopatitis, one of the exceptions of the law, sir.
And also biliary ascariasis?
Yes, sir.
Could that be a cause? Dr. Jairam Shenoy.
So in our time, sir, every patient used to get a Zentel as a first line of medicines in the sheet. So ascariasis was so common. So now as rightly put it, hydatid cyst rupture can give rise to all your tenderness, then jaundice, then bleeding, melena, everything is possible, right?
Yes.
All this, but not in this patient. I'm just trying to tell you that. What is that called as then? If there's a blood into the biliary tract down into the second part of the duodenum, what is it called as?
Hemophilia, sir.
Similar. These are one or two questions. Hemophilia, hemosuccus pancreatitis. These are one or two other, some of the commonly, sometimes the discussion can go also in that direction.
Okay. Due to
What are
positive,
the
move on to the investigation.
Yes.
Since we are losing time, so can we go on to the investigations?
One last
sir.
question,
Yes.
Dr. Arun.
One last question by
Last
Dr.
question.
Subramanyam. Yeah.
What are the localized causes of liver enlargement?
Fecal lobe enlargement can be due to a primary, sir, or more commonly due to single metastasis in the liver, sir.
Single metastasis, HCC, then
Primary
what else?
HCC. Benign lesions are large adenoma or hemangioma.
What is the radial slope of the liver?
It is a accessory lobes are present only in some percentage of the population, but
Yeah,
if
these
it
are
is
the things you have to think of localized liver enlargement.
yes.
Okay.
Okay. We move on. Investigations. What investigations would you want to do, Dr. Akshada?
Sir, I would like to divide the investigations into three. I would like to confirm my diagnosis first, sir. For that, I would like to do a ultrasound of the abdomen and pelvis first, sir.
Is there a slide there?
Rather than making the statement that I want to confirm the diagnosis by ultrasound, it is better that you know how you proceed when the question is asked. You better say that initial investigation is
It
ultrasound.
would be ultrasound. Yes.
Yeah, remember, you cannot confirm it
Confirm
100%.
that.
Yes, sir.
That's how you start with that. Okay. So
Yes.
then the question that will be asked is like, what are the clue or what are the findings which sonologist will tell you to make you further to
Yes, sir.
investigate. So tell me, in your patient.
I would like to see the liver, sir. If there are any lesions in the liver or if the intrahepatic biliary radicals are dilated. I would like to see if the gallbladder is distended and what is the wall of the gallbladder like, sir, if there are any coexistent stones or not. And like to assess the CBD also, sir, if it is dilated and if there are any stones in the CBD. We will also like to see the pancreatic duct and the pancreatic parenchyma and if possible, any nodes and ascites, sir.
See, most of the times the ultrasound, they'll give you bowel artifacts, pancreas cannot be assessed.
Yes, sir.
And distal CBD cannot be assessed.
Yes, sir.
So how do you proceed then?
How will you proceed?
How will you proceed next?
See, again, when you do ultrasound, you'll get to know the ascites also.
Yes, sir.
Any
Nodes
ascites,
can
any
also be
nodes, if it is there, if at all any spleen is enlarged, that
Yes,
also
sir.
you'll get to know.
Yes,
What
sir.
are the other investigations?
Yeah.
I would like to do a LFT, sir, with PTINR, a basic hemogram, and then proceed to do a triple phase CECT of the abdomen pelvis, sir.
Can you
Blood
show us the
urea creatinine you want to check?
Sorry, sir?
Blood urea creatinine you want to check before going
Yes.
to CECT?
Yes, sir.
In the jaundice
Before,
patient.
to rule out hepatorenal syndrome as well as to know the basic renal function, sir, before we proceed with the contrast enhanced CT. Investigation, sir.
Yeah.
So this patient had a hemoglobin of 9.5, sir. Counts were normal. PTINR and platelet counts were normal. His serology was non-reactive. Creatinine was normal, sir. Electrolytes were within normal limits. He had a total bilirubin of 12.5 with a direct bilirubin of 11.9. ALT, AST were also mildly elevated, and alkaline phosphatase and gamma glutamate transferase were significantly elevated, sir.
So what does this tell you?
This looks to be an obstructive pattern of jaundice, sir. ALP GGT elevated with direct hyperbilirubinemia.
And one thing is, what about that albumin? Albumin is only 2.5. Is it important?
Yes, sir. It is important, sir. It is important for the overall prognosis, and if we are planning for surgery, we have to correct the nutrition status of the patient first, sir.
So what does it indicate? Low albumin indicates?
It can be a indication of liver cell failure only, sir.
Yes.
The synthetic function of liver is
Possibility, or his loss of appetite. So nutritionally also, it can be a problem. But albumin is very important.
Yes.
Next investigation.
So, yeah, just when you bring this word nutritional, the question that we may follow, like what maybe the disease he's having since 1 month or maybe more, and every day he may be losing blood also and protein loss. all that questions will come. Is there
Yes,
any
sir.
pedal edema in this patient?
No, sir.
Is there any pedal edema in this patient? No.
No, sir. No.
So with this in the background, so how do you investigate further?
Further, I would like to do the triphasic CT scan, sir, with pancreatic protocol and do a CA19-9 and CA values.
The CA19-9 you have written 235.
Yes, sir.
What's the normal level? Any idea?
It's about less than 30, 34, sir.
Suppose I will put it this way that your place is, you don't have, is it mandatory?
Yeah.
Like you say, suppose, is it mandatory? If not,
No, sir.
If not, why we do it? 2 questions.
It is not mandatory, sir. It is a more of a prognostication and
Good
follow-up
answer.
for CA
So
pancreas, sir.
these values, if they drop down, you know, just like a CA, so in the
Yes, sir.
colon we talk about, so then it has got, otherwise, yes, definitely it is, that is the value of that. So now
Yes, sir.
before you go to that, triple phase findings you should know. And then
Yes, sir.
what's the finding? Anything has been
findings.
done?
Yes, sir. These are some of the CT films of the patient, sir. The gallbladder appears to be grossly distended, sir, with thickness of the gallbladder wall itself. And the CBD is also...
Can you show us on your picture with your pointer? Which is a gallbladder,
Sure,
which is a CBD? With your pointer,
yes, sir. Yes, sir. Yes.
yeah, just show which is a gallbladder, which is a CBD.
Yes. This is the liver, sir. The intrahepatic radicals seem to be a little dilated, sir. This is the gallbladder. The wall thickness of the gallbladder itself is more, sir. And this appears to be the CBD, so the stomach continuing into the duodenum, and the CBD itself is dilated.
Correct.
And these films also we can see gross dilatation of the CBD.
Good.
See, gross dilatation, which we all know now. CBD is dilated, gallbladder is distended, intrahepatic
Yes, sir.
dilatation. So now, what are the specific areas which CT gives you? Because this might have been told already by ultrasound. You are right in showing us gallbladder, CBD. Anything else?
Yes.
Then more information.
Yes, sir. We want to see the region of the head of the pancreas, sir. It is better picked up on the CT scan. And smaller nodes will be picked up better on the CT scan, sir, as compared to ultrasound. Sir.
Anything else?
Anything else? Yeah.
Because
more
small
important.
Nodes,
yes, sir. We also
but
want to see involvement of the vessels, sir, and if there are any aberrant vessels in the vicinity, sir, so we can plan whether it is resectable or not, sir.
Very good. Very good. You need to look at the portal vein. You need to look at the superior mesenteric vein. And
yes,
you need to look at the anomalies of the hepatic artery, if at all, arising from the SMA. That's very important when you are planning to do a
surgery.
And again, when you are looking at the vessels, you have to look what is the involvement of the vessel, whether it is encasing, partially, fully, all those things.
Yes, sir.
Can you put up the CT report?
One question.
Sir.
This what is the contrast you give? Simple contrast.
Yes, sir. Iodine-based contrast will give, sir. Usually.
You can give water also for your information. Okay.
Yes.
Remember, that's simple. Okay. Sometimes we do also non-enhanced CT. Non-enhanced. When it is indicated. If you want to see a calcification background, especially chronic pancreatitis. Okay. That is a type you can use that without enhancement. Otherwise, this is a triple phase. I think you should tell that. Okay.
Yes, sir.
Okay. Sir, I was asking for report. Yes.
CT report.
There is a moderate IHBR and CBD dilatation, sir. Secondary to enhancing lesion in the distal CBD region. Mild main pancreatic duct dilatation is also there. The gallbladder wall is also thickened, sir, about 18 mm. And some retroperitoneal nodes are there. There are bilateral simple cysts, sir. Bosniak type 1 in both the kidneys. And some bilateral pleural effusion is there, sir, with atelectasis.
Can you read out that gallbladder this one details little more?
Yes.
Yes, sir.
Yeah.
A heterogeneous mass-like thickening seen involving the fundus and body of the gallbladder with maximum thickness of 18 mm. Mild surrounding fat stranding seen. They've asked to get a HP to rule out a neoplastic lesion of the gallbladder.
But they've also mentioned enhancing the distal CBD
lesion in the distal
20
CBD.
mm, 2 centimeter. So
Yes, sir.
Now, with this CT findings, do you want to think of any other differential diagnosis, though it's probably a little rare?
It can still be periampullary carcinoma, sir, with cholecystitis. We can put the patient on antibiotics and wait to see if it is settling. If not, it can be a carcinoma gallbladder, which we'll have to rule out with a biopsy, sir.
What is Quincke's triad?
Sir?
What is Quincke's triad? Quincke's triad.
I'm not sure, sir.
Okay. So, I mean, with this, any other differential diagnosis you still want to consider?
Carcinoma gallbladder can be there, sir.
Sometimes you can get concurrent GBCA and cholangio-CA. Rare possibilities, but sometimes you can still get that. That is one possibility when you get a finding like this. But I feel it is more likely to be cholecystitis. So what you told, like you give antibiotics and then wait, maybe, and then repeat an ultrasound to see the thickness.
Yes, sir.
The other thing, otherwise, what other thing can you do?
We can do an endoscopic ultrasound and if needed, get a biopsy from the periampullary region, sir.
So just hold on. There are two different things we are talking. At this juncture, if you asked to proceed, yes, you told about antibiotics, standard gallbladder, all that is not comfortable. If you want to achieve now, you want to see the ampulla, periampullary, just say endoscopy. What is the type of endoscope you are going to use? Tell me.
We can use a side viewing endoscope, sir,
that
to
is
see
what
the
we need.
region.
And you take the biopsy from the they already given you the ulceration. Suppose you don't find any ulcer, what will you do? You are still strong suspicious based on this distal CBD they have written.
If there is no mucosal lesion, we can do an endoscopic ultrasound and look for any.
Hold on. Very close to that. Your periampullary is correct within 2 centimeters. You are not able to get that. This is in the CBD, inside the lumen, not in the proper head.
Then we have to go ahead with a retrograde cholangiography also.
No. Just hold on. So brush cytology. You can give a cut and so some brushing. Yes, definitely it requires then ERCP. So that's what is recommended at this juncture. In case if you are not able to see. So when is the endosono? So if you're still not able to get what's the advantage of endosono?
If it's not a mucosal lesion, sir, it can be picked up on endosonography and even nodes can be picked up, sir. So the tumor can be staged.
Only picking up?
We can take a US guided FNAC from the lesion also, sir.
Yes.
So in addition, just to add on to, because the time, so if you decide to plan to give a chemotherapy for some patients, neoadjuvant like or whatever pre-operative, whether it's a large head mass, doubt is there, whatever, resectable, unresectable, some try this chemo. So you need a histology, correct?
Yes, sir. Yes, sir.
Without the histology, we can't proceed for if you want to give a chemotherapy. So this is also one of the plans. So in this patient, if you are asked side viewing, endoscope and biopsy.
Now, why I was insisting on that gallbladder mass is probably, I mean, I heard of this hemocolysis.
No, sir.
That's bleeding. Does it throw any listen to you?
I don't
if you look at it, when there is a clot in the gallbladder, there is a hemocolysis. When there is a bleeding tendency or there is a trauma or something, probably everything will fit into this case. Short duration history, waxing and waning jaundice, and melena, biliary colic, the pain. Everything can happen in a case of hemocolysis where there is a clot sitting, and it may be the same clot which is down in the CBD also, probably what is shown as a mass. So for all you know, it may be a benign lesion.
Right.
It could be a periampullary CA also. Though it's not a very common condition, it's a little rare one though. So it
Right.
can be common. There are various others. Tell me, I mean, you say you're not heard of it. So then there's no point in asking what are the other causes of that. Sir, Rajgopal Shenoy, sir, could it be a possibility, sir?
Sir, it is nothing because we are now reached the investigation level, probably at a very high consultant levels, rare things like which we keep it in mind, rare things. But if this CT scan is shown with the tender gallbladder, with this patient with the waxing and waning, has been already told, melena. So we'll go on for a periampullary carcinomas. It could be cholecystitis. So see, already patient is a very thick walled. That's what they have written. So I think that's what I consider, but rare things are for later discussions.
Okay. Now, shall we move on to the treatment part, sir?
Correct.
Yeah, the treatment.
So we will put it like this: establish the diagnosis first, then the stage the disease. Okay. So you have just done this CT abdomen. So let us put it like, for the time being, we'll hold on to that gallbladder as distended tense gallbladder. Okay.
Yes, sir.
Time being. So if there's a ampullary carcinoma, periampullary, you are taken a biopsy and CT is already there, no infiltration. Then
Yes,
what
sir.
else? We'll do now, staging workup.
I would like to do HRCT chest, sir, to rule out pulmonary
That
metastasis.
is what is required now because that's a minimum.
Yes, sir.
What about the role of PET scan?
Sir, in this case, if it
Yes.
is cholecystitis, sir, even in inflammatory lesions, the FDG uptake would be high, so it would not help us much, sir. HRCT chest would be a better investigation.
Okay, Bailey still continues to give that, no issues. But I just
Yes,
want
sir.
to tell you that PET is also done. Okay, all right.
Yes,
please
sir.
proceed.
Based on these investigations, sir, we'll classify the periampullary tumor as resectable, borderline resectable, locally advanced, or metastatic, sir. So if it is a resectable or borderline resectable tumor, sir, we can plan for surgery.
How do you prepare the patient for surgery?
In a case of obstructive jaundice, sir, the patient will likely have associated anemia, sir, which needs to be corrected. If the nutritional status as indicated by the albumin is low, sir, we have to give him a high protein diet. Also in these cases, sir, glycogen storage will be reduced in the liver, so we have to give him carbohydrate loading pre-operatively. Then dehydration and dyslipidemia has to be corrected, sir. For the direct bilirubin per se, sir, if we are planning for surgery, there is no need of stenting, sir. But if we are going to plan for neoadjuvant chemo or palliation, then we may have to put in a CBD stent, sir, to decompress the.
Is there any level beyond which you want to do the stenting? Because sometimes the risk is too much.
Yes.
This is a controversial subject, but any idea you have when you want to do the stenting?
But why you don't want to do the stenting?
Yeah. Or you
What is the
don't want
reason
to
why
do
you
it
don't want
at
to
all?
do the stenting?
Sir, if you're planning for a surgery, sir, the stent itself acts as a foreign body and there is a lot of adhesion around the stents, which makes the surgery very difficult, sir, the operative steps.
That is not the actual reason.
Otherwise, sir, it is also thought that it can upstage the disease and introduce infection also into the tracts.
No, what will happen if you put the stent? No, what will happen to the diameter of the CBD?
Once you put the stent and relieve the obstruction, what is going to happen to the CBD?
Dilated CBD is better or small? That is the discussion.
CBD
happens in a pancreatic,
if the CBD, yes, sir.
Sorry.
If the CBD will collapse during surgery, the anastomosis or the choledochord itself will also become difficult, sir.
And Dr. Anil's question now, when do you still consider stenting?
So that various guidelines are there, sir, above 12, in some places 15, but there is no consensus, sir, as to when we can do a prophylactic stenting, sir.
I think more than the levels, what are the definition?
Yes, sir.
First.
So disabling pruritus, sir, patient discomfort, those are also criteria for stenting, sir.
More important than that is cholangitis.
Yeah,
So
Yes,
that
sir.
is exactly what Dr. Ravi Shankar has also put in the chat box. Stent is indicated in subclinical or overt cholangitis, or
Yes,
when the
sir.
bilirubin levels are more than 20 milligram percentage.
Right.
Of course, this
So-
20 milligram percentage, as you said, may be variable, but then cholangitis and probably high bilirubin levels.
Right, sir.
So cholangitis patient, intractable pruritus. Remember one more thing, intractable. See, it's
Yes.
not that, then also most of the people also add now that, sometimes the listing of these cases may not be possible in the near future. See, just to give a few high volume centers also, but there are so much load is there. You can't do it today. It's not a surgery to be done,
Immediately, yes.
take some hours. So keeping all that in mind, but cholangitis is no doubt a strong indication. Levels, I don't know, sir. 10, 15, 20. This is
Very controversial, sir.
Yes, sir. Yes.
So surgery, then what are you going to do?
Before planning for surgery, sir, I would like to also do a staging laparoscopy. If there are no peritoneal nodes even on the staging laparoscopy, then we can offer a pancreaticoduodenectomy, sir, Whipple's procedure.
What did you tell? Peritoneal nodes. See, when you use the word,
Metastasis, sir.
no.
Peritoneal.
Tell what exactly you mean by that. Peritoneal?
Deposit, sir.
Okay, you can call it some nodules, but what you can, they are very small,
Yes, sir.
less than 0.5. So you cannot
Not
put
with
up
the
with a CT scan.
CT
So
scan, yes.
that is the time you require that. Diagnostic, laparoscopy, and proceed. Okay.
Yes.
When do you decide this patient is operable or inoperable? Is it resectable or not resectable?
Sir, resectable
Do you
tumors
think in
are
this patient, is it resectable?
in this patient, sir, it is just a periampular region there. If it is ahead of pancreas, sir, it is said to be resectable if it is confined to the pancreas and does not involve any of the major vessels, or the SMV portal vein or the SMV portal vein confluence, sir. And for borderline resectable tumors, we'll call it when there is less than 180-degree abutment or involvement of these vessels. If more, or if the arteries are involved SMA, then it will be unresectable tumors.
Good enough at your level.
So what is the, yes, same thing, standard. So what is the difference and what is followed? It is the pylorus preserved or Whipple's. What is the difference?
Sir, in the classical Whipples, sir, about the distal stomach, the pylorus, the entire duodenum, and about 10 centimeter of the jejunum are removed, sir. To preserve the functions of the pylorus, a pylorus preserving Whipples or a long mile traverso procedure can be done, sir. Yes, sir.
And with let us say it is not involving portal vein, that is not controversial, whatever patch, graft, all that things.
Yes, sir.
Artery first, all that is a different issue. But with pancreatico PPPD with adjacent field, it was lymphadenectomy.
Yes, sir.
Whatever is the regional there.
Yes.
Sir, is it to continue or to question answers or to continue, or it's okay, I suppose.
Till our host says to stop, probably we can go on.
No, it's 1 hour, 10 minutes. I think
Okay.
we have taken 70 minutes now. So
Okay.
we can wind up another 5-10 minutes.
Yeah, 5 minutes is enough. I think probably another 5 minutes will wind up.
We don't have any specific timing, sir. We can continue.
Yeah, but
last time we had some, last time we had some problems, so we don't want to continue for a long time on online. So that's why conclude in another 5-10 minutes, sir. That will be
another 5 minutes will continue.
Yes, sir. Fine.
There is a question in the chat box. What's the role of MRCP in this case over HRCT or CECT? As per Dr. PP.
Yes, sir. The clinical history and examination findings were suggestive of a periampullary lesion, sir. So we want to look at the pancreas and the pancreatic parenchyma and the duct. So in this case, CECT would be a better investigation, sir. If only we are suspecting something in the biliary tree, then we can go ahead with the MRCP.
No, I just want to add that if you want to really see the pancreatic duct, without ERCP, anyway, which is the better investigation? Pancreatic
The
duct in particular.
best investigation is ERCP, sir. Otherwise,
No. That's invasive, no. So it's the whole
then
issue.
MRCP, sir. For the duct per se,
MR.
MRCP is better, sir.
So
But for
here
the
you are suspecting periampullary
yes,
or
pancreatic.
ampullary. So that is why we think that CCT is better.
Yes,
so
sir.
already it has been told to you, contrast issues related to contrast. Especially, you use the word hepatorenal, but nowadays there is a less tendency to use that word. It is not routinely used. Why do you get those problems in patients with this, what earlier thought as hepatorenal syndrome and all, big way, jaundice patient? What are the precautions you take? One, you said creatinine should be normal. Second, when you are doing a contrast, take care of that. Third is diabetes, if patient may be diabetes. Fourth is what you will avoid. What you will avoid in this patient, he has got pain, you said, gallbladder may be tender. What you will avoid?
NSAIDs we will avoid. Sir.
And yes, very good. And be little careful on the aminoglycosides.
Aminoglycosides, yes.
So that's what happens. It's called as cast nephropathy. It's more than anything. It's a bilirubin cast. So that's what is happening. So your patient has no dehydration. Patient is not diabetic. That way, yes.
Akshada, just forget about this CT report. If you think that obstructive jaundice is secondary to choledocholitis, how will you manage?
If it is choledocholitis, sir, I would like to get a MRCP to confirm the diagnosis, and then we can do a ERCP and remove the stone from the CBD, sir. Most of these stones are not primary stones, sir. They have come down from the gallbladder, so the patient will also require a laparoscopic or open cholecystectomy post the ERCP.
Always you'll be able to clear the CBD?
Not always, sir. Smaller stones are more easy to be cleared with ERCP, sir. Nowadays, we have some newer methods, sir, like spyglass or lithotripsy, which we can use. But if that is not possible, we can go ahead with a laparoscopic or open CBD clearance, sir, for the stone. Exploration and stone clearance.
CBD exploration.
Yes.
Okay.
Whatever method you say, just use a laparoscope open supraduodenal choledocholithotomy. Okay.
Yes.
With closure, with or without T-tube or whatever. Nowadays, no T-tubes.
Yes.
One last
idea of putting T-tube?
Sorry, sir?
What is the idea of putting T-tube after CBD exploration?
Sir, in case there are still retained stones, we can do a cholangiogram and use the T-tube tap itself to clear the remaining stones, sir.
T-tube cholangiogram
and in case there are retained stones, the mature track of the T-tube itself can be used to as a percutaneous channel to clear the retained stones in the CBD.
Choledocoscope, okay. More important than that?
It can also act like a stent, sir, over which we have done the primary CBD repair. So
no. 1 minute. What is the difference between stent and T-tube? You think the bile will pass through the T-tube and pass through the stent?
No,
or
sir.
Stents are placed
one end of the T-tube is outside, sir.
Stents are placed into the duodenum.
Yes, sir.
What about T-tube?
It comes out percutaneously.
No. It will not go into the duodenum. Okay.
Yes, sir. It will be in the CBD.
You get stuck. You can't remove. So
yes,
don't understand when the stent is there, the sphincter of Oddi doesn't work because you are kept open.
A stent.
Another important point you should understand the difference between T-tube drainage versus this. Okay.
Yes, sir.
Okay, lots to discuss and lots to question and learn, but this topic is such, but due to paucity of time, I think we should stop it here. Thank you, Dr. Akshada.
Thank you, sir.
Dr. Rajgopal Shenoy.
Shall I just add one point for here, sir, for clarification?
Yes, sir.
Shall I just add this, Dr. Siddesh here?
Yes, sir.
Namaskara, Siddesh.
Namaskara.
Yes, sir, please.
Very good presentation by Akshada and very nice discussion, very beneficial to the students' exam going. I just want to add because I heard ERCP. See, ERCP should never ever be told as a investigative technique. It is never an investigation today. because we have non-invasive methods to get to the diagnosis. As been told by Dr. Shenoy, it is an invasive method. And even in the best of the centers, there is a complication associated. So only when you are supposed to use it as a therapeutic tool, never as a diagnostics tool. So today's scenario. So don't mention ERCP is a diagnostic tool as an extension. So that's what it is. Of course, rest of the things what you told is absolutely correct. And endosono is good for staging, not only diagnosis, but mainly for nodal status, you can do. So endosono is confined to that. And as been told, CT is superior to MRCP, MR in delineating when you're having a distal CBD pathology. Mainly, again, it gives very good idea about the nodes and peripancreatic pathology, etc. Whereas when you want a roadmap of the bile duct, which you told also, we need MR. That is better. So otherwise, you have done extremely well. I think I don't have anything else to add. A lot of good things have been put points, messages by expert panel. So thank you very much.
Thank you, Dr. Siddhartha, for your concluding remarks.
Yes, sir.
And, thank you.
Well done, Akshata.
Yeah, Akshada, you have done exceptionally well. Really appreciate you. Okay, yes.
Sir, if there are no more questions, I think we can conclude the session. Any other questions? Sir? Questions or comments from Chairman, sir?
Yeah, it was a fantastic program. I think so. All the legends were talking so many things they've highlighted, and most of it has been covered. There's hardly anything to be discussed further, but still there is a lot which we can learn every day. With this, I thank the moderator, Dr. Arun, Dr. Rajgopal Shenoy sir, Dr. Subramanyam and Dr. Anil. Very well done. Thank you. Akshada, you've done extremely well. You have answered everything and you've been quite fair and frank enough to say that I don't know things. That is what you should have. And now I request our Chandru to please present the vote of thanks.
Yes, sir. This is actually a great learning session for everybody. In fact, we have learned a lot of many things in this session, and hope to have such sessions, many sessions like in the future also. And on behalf of KSCASI, I would like to thank Dr. Akshada Easwar for an excellent presentation. Thank you, Akshada. And also, on behalf of KSCASI, I would like to thank today's moderator, Dr. Arun Kumar, and the faculty, Dr. Anil Kumar, Dr. Subramanyam sir, and Dr. Rajgopal Shenoy sir for excellent discussion. And I thank all the members of KSCASI, our past national ASI president, Dr. Siddhartha sir, and all the EC executive committee members, national and state, and the postgraduate students who have joined here for today's clinical case discussion. Thank you, everyone. Thank you, one and all.
All senior faculties from various institutions, including Professor Jairam Shenoy and many others, for taking our time and joining here. Thank you.
Thank you. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you. Thank you, everybody.
Good night.
Siddhartha sir, thank you.
Thank you.
Good night, sir.
And